And our next speaker is Associate Professor Sue Evans, and she's going to talk about the Prostate Cancer Outcomes Registry and its link to understanding and improving quality care. And Sue Evans is the Director of the Centre of Research and Excellence in Patient Safety at Monash University. So please make her welcome.
Thank you. So Patricia thought she had a hard gig after dinner, after lunch. I have a hard gig because I'm not only an hour later than her, I'm also talking about data, and information and data is sometimes enough to put a lot of people off to sleep. But I'm hoping I'm going to keep you engaged for the next 20 minutes or so. First of all, before I forget, I'd just like to say thank you to Prostate Cancer Foundation for giving me the opportunity to speak to real-life people who have got prostate cancer and their carers and their spouses and family and friends, because I'm often sitting myself in a university and looking at information, and I rarely get the opportunity to interact with people in the community on prostate cancer. So I'm very grateful for that opportunity. I'm going to start by talking to you a little bit about the Prostate Cancer Outcome Registry, and then I'm going to talk about what we do. And first of all, I'm curious to know how many people know or have had any involvement with the Prostate Cancer Registry. You might have got an explanatory statement in the mail, and somebody rings you up 12 months after your diagnosis and asks you some questions. Do we have anyone here that has had? Wonderful, good. And I'm really pleased to see and to say that we got Ballarat on board a few months ago now, and Bendigo. So we are now capturing 90% of men diagnosed with prostate cancer in Victoria, which has taken us a while to get there. And I've got colleagues up the back there who I'm very grateful to for helping us to get to that milestone. We're aiming for 100%. In the next few years. So what does a registry do? Well, I think I like this expression from Ralph Brindis. He says, science tells us what we can do, guidelines tell us what we should do, and registries what we are actually doing. So a registry is a database that collects information on people with a diagnosis of a disease or managed in a particular setting in a hospital, and it follows them up to see what sort of treatment they get. And you might say, well, what's the value in that? But having data is really so important to understand what's happening with the disease, to inform policy development. You can't imagine going to a football match and not knowing what the scores are. Yet with prostate cancer and so many other cancers, we find out what the number of patients are who has been diagnosed with prostate cancer through the Cancer Registry. And we know how many people die from prostate cancer. But there's a huge journey in between. At 5 years after a diagnosis, 95% of men are living with prostate cancer, and we need to know what those men are experiencing, what treatments they're getting, whether there's disparity and variation in the treatments that are offered to them, whether all men are getting the type of care that we expect that they should be getting. And that's what the registry does. It monitors the quality of care that you receive. And what we do with that information is provide evidence and care guidelines back to the clinicians and to the hospitals, showing how they're going. We do benchmark our outcomes, so hospitals are comparing themselves and clinicians can compare themselves. And doctors, for those of you who are not aware, are often a very competitive bunch. So if you're giving reports back how they are going, then there is a continuous improvement cycle going on, because people want to do better. All doctors want to do well, and sometimes there are support services within hospitals, and sometimes there are clinician factors, and sometimes there are patient factors that mean that perhaps evidence-based care isn't being delivered as well as it should do. What we want to do is provide this information with the ultimate aim of improving quality of life to men living with prostate cancer, improve survival. It's also really important when you collect information that it's provided to government, that it's provided to hospitals to show them what sort of resources are being used, how many men are getting diagnosed with prostate cancer in various areas, why some people in some areas of Victoria are getting diagnosed much later than in later stage disease than in other areas of Victoria. We know that there's a threefold variation in diagnosis of prostate cancer with high-risk disease. So some men in regional areas of Victoria are much more likely to get diagnosed later on with their disease than other areas. And that has really important implications for education, for resources, and to try and sort of prevent that disparity, or at least act upon that disparity. The registry aims to also be able to provide education to consumers. So we do have a website where you can go and have a look at what your trajectory or what the pathway of your disease will look like according to the normal sort of population averages after different treatments, and whether you're receiving a prostatectomy or radiotherapy, or perhaps just active surveillance. And also registries are really important because it's a database that's got a large population of patients in Victoria. We now have 20,000 men on the registry, and that obviously provides a real wealth of information for us to do some important research to understand what interventions we can put into place to improve the quality of life and the survival for men with prostate cancer. So this is a registry. In the middle is the registry itself, but we collect data from a whole lot of different data sources, from hospitals. In private practice, we find that most of the data is actually collected in your consultant's consulting rooms. So we have people going into consulting rooms and collecting information there. We get some information from the pathology laboratories as well, and we also get information from the cancer registry. So all of those information sources go into the quality registry, and we're really very mindful of the importance of that data and that we keep it very secure. It's held in a database that has bank level security on it, and we don't just give it out. We have to make sure that people who want to use the data that we've got only get access to de-identified data, so you'll never have your name released to another person or another researcher, but where it's had ethical approval and where we know that the research is really going to benefit the prostate cancer community, we provide information and data to those people. The registry itself has to make sure that there's very tight control, not only on the data, but that we have our ethics certificates up to date, and that we control the data itself. And then, of course, the registry itself provides some really important reports back to clinicians and back to hospitals at the moment, providing details of how the hospitals and the clinicians are going relative to everybody else, and on particular quality indicators. Those quality indicators are what good care looks like. So that at the moment there are 12 quality indicators, and those reports go back every 6 months, and we've seen some amazing improvements over the now 8 years that the registry has been running. So just in a nutshell, we get information from the cancer registry. The hospitals have to have ethics approval to pass their data through to us, and you men with a diagnosis will get a letter from the prostate cancer registry inviting your participation. We actually use an opt-off model, and the reason we use an opt-off model is we really want to make sure that we can monitor the quality of care that's happening in the hospital and with the clinicians, and we know that if we use an opt-off response, then there will be some people who don't want to be involved. A small percentage, about 2% of men are not interested, and that's fine, but we get quality information on about 98% of men who have been diagnosed with prostate cancer, and that's really important because it's what is real-world experience, and we're getting almost everybody. So we send a letter out, and you will, if you're on the registry, get a phone call. We try to contact everybody. We do contact everyone. Not everyone picks up, but we get about 85% of people picking up and answering questions from us. We ask a very small set of questions about your quality of life. So that information is then fed back to the hospital and the clinician, and they can see whether their resources are providing a good service to the men. So we monitor care. We want to see what's happening in the prostate cancer world, and this is an example of what we see over the last few years in terms of the way in which men are being diagnosed with prostate cancer. It used to be mostly that all men got trust biopsies, and many of you may have had a trust biopsy, but increasingly we're seeing more transperineal biopsies. So that's really interesting because we want to see what impact that has on future care as well. We also monitor the disease stage at diagnosis. Now, this is an overall pattern for all the men, but we like to break that down also by environment and area, and integrated cancer services, many of you may have been aware of, but different hospitals, just to see whether some men are getting diagnosed later than others. But you can see that there is a little bit of a change over just this short period of time. And if we break it down particularly into risk groups, now a risk group is what happens when we look at your risk of disease progression, so how likely your disease is to progress. And that's based on a number of your blood tests, your PSA level, the biopsy result, and the examination that the doctor does. So all those three things give you a risk group. I'm not sure whether you heard about that today. Maybe not, but you should ask your urologist or your practitioner if you're interested to know what your risk group is. But the risk groups are really important for clinicians because that will help to understand what treatment is advisable for you. And increasingly, the men who are diagnosed with low-risk disease are being encouraged to go on to active surveillance rather than active treatment, because we know that if you have treatment and you're in the low-risk disease, you're going to live for a long time with all the quality of life impacts. Yeah?
Explain the slide. You're talking to us and you're not explaining.
Sure.
So I request to explain the slide.
Sure. So what you can see here down the bottom is a time, over time, so from 2010 up to 2016. And this is for men who have got low-risk disease, and there are different treatment paths that men with low-risk disease can take. They might have surgery, or they might have brachytherapy, they might have seeds implanted, or they might have external radiation, or they may have active surveillance or watchful waiting. So, sorry, I apologise, I should have done that. So what we're seeing on this slide is that between the period of 2010 to 2016, we're seeing more men who are having active surveillance and watchful waiting rather than surgery. Back in 2010, you were much more likely to be offered, or men were more likely to have surgery for their prostate cancer with low-risk disease. But we now know that that's not the best thing, because surgery has complications and surgery has longer-term impact on quality of life. For example, urinary problems and bowel problems, or not so much bowel problems for surgery, but certainly sexual function issues. So what the guidelines are now saying, and the urologists and the hospitals are now encouraging men to have active surveillance for their low-risk disease, which means they watch and see. They monitor the blood tests and do a biopsy every couple of years to make sure that things are not progressing. And if everything's good and dandy, then you stay on active surveillance. And men stay on active surveillance for many years, maybe never have treatment, because the disease doesn't progress. And in a lot of cases, the disease doesn't progress. In low-risk disease, you're more likely to die of other causes than you are to die from prostate cancer. So we're very keen for low-risk men to be encouraged to take up active surveillance. The registry also monitors quality of life after different treatments as well, to show how you're going. So this again is looking at the bottom part is months after surgery, and it's showing that for urinary function after a prostatectomy, you're not very likely to have a urinary obstruction. That's very rare, but you are in the short term likely to have some urinary incontinence, and that gets better, but doesn't usually get back up for many men to what they were prior to their surgery. Similarly, we're seeing in the real world that when men have surgery, they immediately from baseline have a decline in sexual function, in being able to have an erection, and that does come up a little bit, but still there are many men at 12 months and thereafter who have sexual problems after their surgery. I think the value of the registry is that it does give real-world experience and understanding of how men are going to go, because we get almost the entire population. Clinical trials may say that everything's going to be great, your life is going to get back to normal, but the evidence is not telling us that. And I think that having a realistic expectation of what your recovery will be after surgery is really important to men and partners and family members. So these are the reports that we're sending back to the hospitals and to the clinicians, and it's asking them, well, it's giving an indication of whether care is being delivered according to evidence-based guidelines. Are men with high-risk disease getting treatment? Because we know that in some areas men are not getting treatment, and they should be getting treatment if they have high-risk disease and they have a good chance of having a 10-year survival, then they should be getting treatment. But unfortunately, there are men who fall through the cracks. So the registry's really got a really important task of making sure that that does happen. And now, increasingly, we're making sure and monitoring that men with low-risk disease don't get treatment. The counter to that, because we don't think that it's appropriate, and the guidelines suggest it's not appropriate for men with low-risk disease to get treatment. The registry compares surgical outcomes across different types of surgery. So open, and many of you who have had prostatectomy may have had laparoscopic surgery, or you may have had robotic surgery. So the registry is keeping an eye on what's happening with the differences in outcomes from whether you have a prostate removed through a robot, which is sometimes becoming increasingly popular but is also expensive, and just checking and reporting back on whether you're actually getting a quality of life benefit from that. And also obviously looking at what are the quality of life issues. So we've seen some improvements in prostate cancer care since the registry began, and we continue to see those improvements. We're seeing a halving of the surgical margins, so positive surgical margins. So when your prostate is removed, the aim is to remove all of the prostate and not get any cancer out to the outside of the prostate, so that you are less likely to have radiotherapy afterwards. So we really want to make sure that where possible, there are no positive surgical margins. Sometimes we can't help that, because if the disease is a high risk and it's extensive, then you are going to have positive margins. But we want to see that that there is a reduction in positive surgical margins through training, education of registrars and doctors in the surgery. And we've seen a threefold reduction in men with low-risk disease undergoing surgery, which is the low-risk disease that I was talking about. So feeding back reports does make a difference. It does improve adherence to evidence-based guidelines. And we've seen more men with high-risk disease getting treatment. Now, that's pretty high anyway. More than 90% of men were getting treatment. But even so, there are still 10% of men with high-risk disease that back a few years ago weren't getting treatment. So we're seeing an improvement there. So the registry collects information on patients, on men, and sends information back to hospitals, but we decided not long ago that that really wasn't good enough. We were sending reports back to clinicians and highlighting men who reported when we spoke to them over the phone that they were having a big bother. But we weren't really quite sure what was happening, whether they were being recalled, what they were doing. So we've just embarked on a project not long ago to interact more closely with men who report moderate to big bother when we ring them up at 12 months. So men who want to be involved and have a care coordinator in the regions that were participating in this trial signed on to having a care coordinator. And this was done with the approval of the hospitals and with the approval of the doctors. And what we were wanting to look at was whether that actually made a difference. So the care coordinator would would ask them a lot of questions and would tap them into physiotherapists, to psychologists, to dietitians, to exercise physiologists. So it was a matter of gathering the information on what their needs were, if they had some unmet need, and trying to give them some support where they may have required it, because they were reporting to us that they had a moderate to big bother. So it was a problem to them. And what we found is that over that 12-month period, we've seen a 70% response, a 70% improvement in that group that had the intervention, the care coordinator, compared to men who historically didn't get anything. So there's something in that. We need to explore that a bit further, but clearly there are only a small percentage of men who have a moderate to big bother and want to have access to a service, but where they do and they reach out for it, it's helpful. I think that's really important. So we're really excited about the next steps for that. We publish a lot of feedback on and results from the registry, because we want to make sure that care's improving and we want to understand it more. So there's lots of research that we're producing out of the database. Registrars and other doctors and researchers are using our data. And I can't tell you much about this because I'm embargoed until Monday, but I will just, because it's not on the slide, I'll give you a bit of a sneak preview, because it's really quite important. I don't know how many men here are on active surveillance. Okay, and what this study did, which is published in the MJA, and Melanie over in the corner is the first author on that paper, we looked at, for men who were on active surveillance for 2 years, how many of them had 3 PSA levels and 1 repeat biopsy. Now, that's the minimum requirement that you should be getting if you're on active surveillance. So any ideas on what percentage of men, and there were over 1,600 men, what percentage of men on active surveillance would have been getting those 3 PSA levels and that 1 biopsy? Yep. How many, what percent do you think?
I've been 2 years.
Yeah? And have you been you've been doing your blood tests regularly?
Yes.
Yeah?
I wasn't sure whether to come out with the microphone or not, but...
Yeah?
Anyone want to... 20%.
Yes. A little more. 25%, only 25% of men in a population in Victoria are getting 3 PSA levels and biopsies in that first 2 years. Now, we may have missed some that have gone back to their GPs and not presented back to the hospital or to their clinicians' consulting rooms with their blood test results, but even that is quite staggering. And it's so important. We're now encouraging men with low-risk disease to have active surveillance. It's incumbent on the hospital and it's incumbent on the men themselves to understand what that means, and that you have to have your blood tests done, because we want to keep an eye on it. What we don't want to see is men falling through the cracks, going on active surveillance and actually not getting their blood tests and coming back years later with metastatic high-risk disease. So, the registry has identified this. I'm sure will be media around it. But, really my message to you, if nothing else today, is if you're on active surveillance, and please just make sure that you are checking your PSA levels and getting a repeat biopsy.
I need to finish.
Yep. Contributing hospitals, and I'd like to acknowledge my funding sources, and certainly the Movember Foundation. Many of you will know Movember and the Monash. They provide the funding, so I'm very grateful.